Good afternoon, everyone. We are going to start our next session. Hope we all can focus after that excellent lunch. But we have a good speaker, so I think everybody's going to be awake. I'm Chirag Desai. I'm a transplant and hepatobiliary and pancreatic surgeon at University of North Carolina. It's my honor to chair this session with my colleague.
Hi guys, my name is Juan Gurria. I'm a pediatric surgeon at Cincinnati Children's, surgical director of the TPIT program there. I hope your eyelids are pretty stimulated right now. It is if we can take a seat, guys, please. It is my distinct honor to introduce our next speaker, the first for this session, Dr. Jennifer Ladd. She's a pediatric endocrinologist at Nationwide Children's Hospital and an assistant professor in the Department of Pediatrics at The Ohio State University, where she leads the endocrine efforts on the TPIT program. She's going to talk to us about what have we learned of the eyelid evaluation pre-TPIT and early post-TPIT management. Welcome.
All right, thank you very much for that kind introduction, and thank you so much to the organizers for having me today. It's really an honor to be up here amongst all of the big names. So I have no disclosures, but over the next 30 minutes, Dr. Bellin and I will take you on a journey through TPIAT from an endocrinologist perspective. For those that are less familiar with what TPIAT is, I will explain it as an endocrinologist, that it's a complex surgical procedure offered to selected patients with acute, recurrent, and chronic pancreatitis to relieve debilitating pain and improve quality of life. So the pancreas is surgically resected along with many other organs seen here, and the small bowel is reconstructed. From an endocrine standpoint, as soon as that pancreas is surgically removed, patients have insulin-dependent diabetes. And that's where eyelid autotransplantation comes in to allow for the potential of remission of diabetes long term. So as you can see here, the islets are purified from the surgically resected pancreas and reinfused, often through the portal vein into the liver and sometimes into secondary sites such as the small bowel mesentery. Now, I will say that this slide highlights the beta cells in the islets, but as we have heard many times today, there are also other cells within the islets, like alpha cells, which produce the counter-regulatory hormone glucagon that are really important for glycemic homeostasis. Now, from an endocrine standpoint, there really are no contraindications to TPIAT, so even if a patient has pre-existing type 1, type 2, or type 3C diabetes, patients can still be offered TPIAT, and at our institution with the IAT part, as long as there is some residual C-peptide or beta cell function. Now, of course, IAT cannot cure diabetes once it is already in existence. So from our standpoint, the earlier that TPIAT is done, the better, before there is evidence of islet cell dysfunction. So that brings us to the question of how well do these islets actually work in pancreatitis pre-TPIAT? And we have already heard from a lot of speakers today that these islets really don't work as well as we may hope. So the prevalence of diabetes in pancreatitis is many-fold higher than we might expect from the general population, and studies have shown that up to 8% of children and 30 to 40% of adults with chronic pancreatitis will develop diabetes. And longer term, that prevalence increases such that after 20 years of disease, many patients with chronic pancreatitis will also have type 3C diabetes. And as we've heard today as well, even a single episode of acute pancreatitis can increase the risk of diabetes. So one study has shown that up to 15% of adults may develop diabetes within the first year of acute pancreatitis. And if we've heard from the Hungarian group today, up to 40% at 5 years may have prediabetes or diabetes as well. So the question then becomes, well, before there is overt diabetes, is there evidence of islet cell dysfunction? So our group at Nationwide is conducting a prospective cohort study of youth with acute pancreatitis. without pre-existing endocrine or exocrine dysfunction. And someone mentioned a continuous glucose monitor earlier, but we are placing one of these at the episode of acute pancreatitis during admission and 3 months later. What we get is a 24/7 graph of glycemic data, an example of which is shown at the top here. In gray is normal glycemia, and yellow is higher glucoses than we might expect. And as you can see here, many of the CGM parameters are significantly different at acute pancreatitis and at 3-month follow-up when these patients have returned to their baseline state of health. Specifically, a higher mean glucose and more time spent in hyperglycemia during an episode of acute pancreatitis than at 3 months follow-up. I'd also like to specifically highlight this time and tite range, which is really gaining traction in our kind of type 1 and type 2 diabetes world, but really is keeping those blood sugars very normal, which are the blood sugars that we target after TPIAT in this 70 to 140 zone. And you can see that not much time was spent during the acute pancreatitis episode in that zone, but it significantly improved at 3 months when patients were back to their baseline state of health. I will say, however, that this time and tite range of these patients does not match that of healthy children that's presented in the literature. In those kids, we expect more 95 to 97% time and tite range versus the 91% that we've seen here. And Dr. Bellin's group has done some more mechanistic studies showing that early metabolic changes are evident even before diabetes develops. So in this study, they compared 25 patients with chronic pancreatitis without diabetes to age, sex, and BMI matched healthy controls. And in this study, these are figures from the intravenous glucose tolerance testing showing that those with chronic pancreatitis have decreased insulin sensitivity and a lower disposition index than healthy match controls. And the disposition index, as you heard about earlier from Dr. Hart, is really a measure kind of adjusting insulin secretion and insulin sensitivity. The same study showed that calcification may affect endocrine function as well. So these data are from mixed meal tolerance testing. So oral ingestion of a standardized ratio of carbs, fat, and protein, showing that those with calcific CP have a lower C-peptide and lower glucagon secretion than those with non-calcific CP, although it didn't reach statistical significance, potentially because of the small sample size. We also know that autoimmunity can affect endocrine function, and these are data from the Cincinnati group showing that actually there's a much higher prevalence of autoimmunity in our patients with pancreatitis than we would expect in the healthy population. So in this study, 12% had evidence of any autoimmunity and almost 6% with multiple antibody positivity, which is much, much higher than we'd expect from our general population of kids, where we're only seeing about 0.5% with multiple autoantibody positivity. As we might expect from our type 1 population, those in the antibody positivity group had a higher proportion of those with pre-diabetes and diabetes than those in the antibody negative group, as well as a significantly shorter time from acute pancreatitis to development of diabetes. So now that we know that the islets may not work very well pre-TPIAT, what can we expect post-TPIAT? And before we discuss the early post-operative period, it's also really important to discuss islet yield, which is the quantity that I think all of us think about and talk about as islet equivalents per kilo being the strongest predictor of insulin independence long-term. There are many, many factors that affect the islet yield, some of which are listed on this screen and some of which we'll discuss in following slides. But all to say that this is a quantity that we can really only know intraoperatively, although we have some ways of trying to predict this before. So again, from the Minnesota group, Dr. Bellin has shown that both age and disease duration do affect islet yield. So in this cohort of 64 patients with PRSS1, The islet equivalent per kilo was reduced by 13% for each 5-year age increase, and by 22% for each 5-year disease duration increase in those with PRSS1. Another study from Minnesota also showed that increasing fibrosis was associated with a lower IAQ per kilo. So here, increasing degree of inflammation and increasing degree of fibrosis were both inversely correlated with the islet equivalents per kilo. Calcification may affect islet yield as well. So these are studies from Baylor and UNC. So in this study of about 200 adult patients undergoing TPIAT, diffuse calcification was significantly associated with lower islet equivalents per kilo. And it was associated with lower islet equivalents per kilo compared to not only those that were not calcified, but also those with focal calcification. And there's a brand new publication from Dr. Desai's group here with 32 patients 32 patients with chronic pancreatitis undergoing TPIAT, showing that the location of calcification also matters. So they found that increased calcification burden in the body and the tail, but not in the head, was also associated with lower IEQ per kilo. And again, from our colleagues down the street, our Cincinnati group has also been looking at pre-op imaging to see if that can help predict islet yield, and has found that in this study of almost 80 patients who had an MRI pre-TPIAT, that pancreas volume, T1 signal intensity ratio on the MRI were significant predictors of pellet volume. And again, as I've mentioned, and as I'm sure a lot of you know, higher IAQ per kilo is really associated with early insulin independence. This was a study out of Minnesota of 75 children who underwent TPIAT, showing the highest rates of insulin independence even early at only 6 months post-op in those with the highest yield group, so those with greater than 5,000 IEQs per kilo. About 50% of those were off insulin by 6 months, compared to the under 2,500 IEQ per kilo group, or the low group, where only 13% were off of insulin. I think the converse here is also really interesting, showing that about 50% of those in the highest group still were not off of insulin at that time. And it's interesting that even in that low yield group, that even 2 were able to come off of insulin at all. So clearly we know that yes, quantity is really important, but the quality of these islets also matters. As just a very brief case study of that, I'd like to show some histology from one of our teenage young adult patients who underwent TPIAT recently and had pre-existing what we would call type 1 diabetes, so multiple antibody positivity. A1C was 10% prior to TPIAT. So these are histology slides. I am not a histologist, but essentially the DTZ staining lights up the islet red and the acinar cells are beige. And this is what we would have expected her islets to look like, so really diabetic islets without any insulin staining, or excuse me, DTZ staining at all of those islets. But what we saw was actually her islets matched more of the healthy control than the diabetic control. Her islet yield was also actually much higher than we might have expected at 2,700, so showing that, yes, quantity is important, but also clearly the quality, since these islets were not working well even preoperatively. Now, stress during the isolation procedure can affect how many islets are isolated, but we also know that there are lots of other stressors along the way that can affect islet survival. So there's the immediate blood-mediated inflammatory reaction that causes significant islet loss initially. These islets, if they're going through the portal vein, are often in a relatively hypoxic environment. They don't have their usual innervation that they would have in the pancreas. And then there's, of course, metabolic stress, so any hyperglycemia during recovery. And we know that all of these can lead to beta cell apoptosis, islet loss, and then thus less islet survival long term. From an endocrinologist perspective, I'd like to take the last minute just to talk about glycemic management because it raises some challenges that we don't see in our type 1 and our type 2 population. And we know that this time in tight range, keeping these blood sugars really normal, are important to islet survival. So these patients, unlike some of our others, may have post-operative stress, complications, infections related to asplenia. There may also be delayed gastric emptying, concerns with adherence to insulin, but also PERT, which can lead to a mismatch between the onset of insulin action and when we're absorbing our nutrients. And then there are also limitations to technology in this setting. So we rely very, very heavily on insulin pumps and continuous glucose monitors as endocrinologists to help our families improve glycemic management. And the Cincinnati group has shown that insulin pump use is better than injections post-operatively, as we might expect, since we're able to deliver more precise doses of insulin. So in their study, there was a higher proportion of pump users off of insulin with better graft function than MDI or multiple daily injection users. However, there are definitely limitations to this technology. As with any technology, it can fail, but also in this population, we use medications that might interfere with the accuracy of our continuous glucose monitors. So our group conducted a study where we had patients where both of the commercially available continuous glucose monitors over time and compared the values to the gold standard point of care. These are Clark error grids, and essentially you want all of your values to fall in the A and B zones to show that those are acceptable values versus falling in C, D, and E, which would lead to clinically inappropriate decision making. So for example, giving insulin when the blood sugar wasn't actually high. So all to say is we teach our patients to trust technology, but not completely. So what have we learned? We've learned that even in the setting of clinical normal glycemia, subtle islet dysfunction is already present in those with acute and chronic pancreatitis. And we've learned that quality is important, but also quantity. And with that, I'd just like to thank our TPIAT clinical team, my research mentors, especially Dr. Freeman, Dr. Nathan, and Dr. Bellin, to whom I will turn it over to discuss islet and beta cell function longer term.
Next speaker doesn't need much introduction. It's our president, Dr. Bellin, who is a distinguished professor at Minnesota, and she's going to talk about the long-term beta and alpha cell function after the TPIAT.
Hi, good afternoon, everyone, and thank you for that wonderful introduction to TPIAT and the islet infusion process and early outcomes. I'm going to focus primarily on long-term outcomes. Here my disclosure is not particularly relevant, except that I will talk a little bit about CGM. Relevant to Dexcom. But I'm going to talk mainly about beta cell function, not because it's the most important, although I think beta cell function is quite important, but it is actually where we have most of the data. So we're going to focus mostly on beta cell function, but because we always talk about beta cell function, I also wanted to give you a little bit of background on what happens to the alpha cells, what happens to our endocrine hormones, the GLP-1 and GIP after our surgery, and then hypoglycemia after TPIAT, because I think these are topics that we maybe don't talk quite as much about. And islet transplantation is really interesting in terms of the exocrine-endocrine interactions, because obviously we do this for an exocrine disease, but here we have islets that are functioning outside of the exocrine setting, right? And so this question came up earlier, I think it was from Suhail, about what about the acinar tissue? It's hard to get tissue to really test in these patients, but as far as we know, the acinar tissue doesn't survive the islet transplant process, so we think that these are just islets independent of any exocrine tissue after they're transplanted. So I'm going to have one and only one slide on pain here, and this is the reason we do the TPIAT at all is because these patients have pain. We want to restore their quality of life. There's going to be the pancreatitis session organizers have included a really interesting debate on when to use TPIAT tomorrow, and I think that will focus more on the pain aspects. But I didn't want to leave out the fact that this is why we do this. We have our recent multi-center post-study published in TPIAT. 12 centers in the US contributed to this. We did see that there was a great reduction overall in pain score, improved quality of life, which is in that spider diagram. That's probably hard to see, but the inside spider there is baseline, and the blue and yellow are 6 and 12 months in terms of quality of life parameters. Half having seldom or no pain after surgery, improvement in anxiety, improvement in depression, improvement in pain interference scores, really, really robust SF12 improvements. And so that's why we do the surgery, but I'm going to tell you the rest of the day about the diabetes outcomes. That's just sort of a bonus. So you're going to take someone's pancreas out. We hope to actually try to minimize the severity of their diabetes when we do that. So what do we know about that? So first, starting with the multi-center data that we have from the POST study that I hope is fairly generalizable, because we were recruiting sort of all comers at the institutions who are participating in POST. And so trying to get as unbiased a cohort as possible from these 12 centers. And looking at that, when we looked at islet function, looking at C-peptide as our marker of islet function, in this case just fasting C-peptide, insulin use, and A1C, we see that at a year after surgery, 83% of these patients had islet function. So they had detectable, meaningful C-peptide, 20% were off insulin, and 60% had an A1C less than 7. If you looked at their preoperative factors, taking kind of islet yield out of the picture, or looking at hemoglobin A1C before surgery was probably the most important predictor, because it predicted all of these outcomes. Young age also predicts insulin independence, and C-peptide beforehand predicts islet function afterwards. But that's the one-year outcomes, and I told you I was going to tell you a little bit more about long-term outcomes. And so within the grant funding cycle, we weren't able to follow all of these patients out to 4 years, so that's a limitation of POST, but I think the people we did follow are mostly reflective of our general population. And if you look at out to 4 years, although we had 80% of patients using insulin at 1 year, so 20% off, once you go out to 2 to 4 years, that actually improves a bit, and so it's more like 30% off insulin at 2 to 4 years. Our A1C level on average was 7% at 1 year, but it does go up a little bit, but still I think for someone who doesn't have a pancreas, mean A1Cs of 7.2, 7.3, that's better than what we get in type 1 diabetes oftentimes. And then most of these patients actually do retain islet function. We didn't see much change in islet function across time. So these outcomes seem to sustain at least out to 4 years in our multi-center data. So one of the really interesting things that we've been able to observe at our institution, because we've done many pediatric cases and many adult cases, has given us this opportunity to look at what happens in a child who has this procedure, who has sort of younger or juvenile islets, what happens in an adult that has this procedure. And one of the things that we observed many years ago was that kids seem to do better, and particularly these kids that were very young with hereditary pancreatitis. So these kind of 3 to 10 or 11-year-old children seem to really robustly have the best outcomes. And so we looked at that a little bit more recently to look at not just insulin independence, which is what I'm showing you here, but the actual function of the islets. So measuring actual islet function by C-peptide to say, is there something different about these islets? So what I'm showing you here is from 134 kids, and 52 of them we considered young. They were 3 to 11 years of age. And then the other 82 were adolescents, so they were 12 to 18 years of age. And if you look at the insulin independence, the young child group, which is gray, has a more robust off insulin rate. They had a little bit of a higher resuming insulin rate long term, but that was just because more of them started off, so there were more patients to actually resume taking insulin. But they do have a higher off insulin rate of over 50%. So we looked at what's happening with those islets, because part of the question was like, is there something about young islets that really can survive, right, the stress of a transplant and maybe the stress of pancreatitis, or is this just like, well, little kids don't need that much insulin, right? And so like, it's easy to treat them and get them off insulin. So what we saw was we looked at these mixed meal tests where people drink a boost beverage, and we looked at C-peptide from that and glucose from that. And early on, it actually didn't look all that different, but once you start to go out to 2, 3, 4 years, and considering what the C-peptide was for what the glucose is, right? So when you're looking at C-peptide, it's really important to understand what the glucose is too, because there's a ratio here of C-peptide to glucose. Once we get out to that 2 to 4 years, then we're seeing better islet function, actually maybe improving islet function slightly in these young kids compared to these adolescent patients. So there does seem to be something that perhaps is intrinsically more resilient, maybe has the potential to expand, although I think that would be very speculative at this point, but there are autopsy studies that would say, young kids have more ability to do beta cell replication. So something about the islets in these young kids, these younger islets, seem to have more resilience, more capacity to withstand this stress of transplantation. But I will say, young kids, adolescents, adults, anyone we're looking at, we do know that there's attrition of islet function over time. So when we take these islet, and we see this in allotransplantation, which actually, if you look at this over here, this is a type 1 diabetes donor islet transplant with immunosuppression line from the Collaborative Islet Transplant Registry. So we see this in auto transplants and allotransplants when they start with a high mass. You can see if you have immunity, you're getting a donor transplant that you can reject or have recurrent autoimmunity, you actually lose insulin independence relatively fast. And that's probably because of the immune variables and the fact that things like tacrolimus that are routinely used in transplantation are not great for beta cells. But if you looked at the auto transplant, which is this blue line here, you still see an attrition. It's just not as rapid as these patients who may reject or have autoimmunity or have toxicity. And if we looked at our auto transplant patients, which is the right, and look long term, remarkably, we see these patients who still have insulin independence at 10 and 15 years, which here, white, full function is insulin independence. But it does decline over time. And here I'm going to ask you to just ignore this graft failure, which I think was poorly defined in our early studies because we didn't have C-peptide. It's defined based on insulin use. If you look at C-peptide, most of those patients actually have islet graft function, but we definitely lose insulin independence. So we wanted to look at this a little bit more closely about how well islets were surviving and functioning long term, and what type of effect that had on glycemic control and actually diabetes complications, but I'm not going to give you the diabetes complications data today because we're still analyzing that, except I will say it seems to be very few who have complications like retinopathy. But we invited back a group of patients who had their TPIAT at any age. This includes people who were children, even young children at the time, and people who were adults when they had their TPIAT. But because of the blood draws, they were 16 or older at the time that they underwent study. So these are near adults at least, or adults at the time that they had study. And you can see here that they're 9.5 years out from surgery. So these are patients who are almost a decade out from their surgery. I think that the people we got back were fairly reflective, maybe not perfectly so, but fairly reflective in average islet yield of what we see, about 4,000 islet equivalents per kilogram. And the people we got back, we had some patients who truly had islet graft failure by C-peptide, but it was only 8% of them. Of these patients coming back, 32% were still off insulin, and then the other 60% actually did have C-peptide and had function. And what you can see in here, if you look at A1C, at insulin dose, and CGM data, time in range and time in tight range, which Jen so nicely introduced here, you can see that overall we have really tight control in those patients who are off insulin, like, close to normal. They're not normal, but they're close to normal. And even in the patients who have partial function, we have pretty good control at 10 years post-surgery, 67% time in range, A1C of 7%, which is great for diabetes. By comparison, the patients who had graft failure, and we also had a couple total pancreatectomies that aren't shown here, they had worse glycemic control. And so, really the reason that we did this study is we expected to see this, but there's some skeptics, like people at CMS who don't want to pay for islets, who said you don't necessarily get better control with an islet graft, and we wanted to show that you did. And so I think this data really shows that those islets can function long term. They can improve glycemic control to have functioning islets, even if you are not, or even if you are on insulin, even if you're not insulin independent. So one of the other things that we wanted to look at out of this study, though, is why, so if these patients they can't reject their islets, they're their own islets, they're not taking immunosuppression, they don't have autoimmunity, most of them, with some exceptions, as Jen noted, but most of them don't have autoimmunity. Well, why are they losing insulin independence, right? What's happening or unique about these islets in the liver that they're not sustaining over time? And one of the things that we've always thought is that these beta cells are stressed. And I think what we can't say for sure is what they're stressed by entirely, but we have a marker of beta cell stress that's used in the diabetes world, and that's looking at proinsulin to C-peptide ratios. So proinsulin is the precursor molecule to insulin and C-peptide. When a beta cell is stressed, this proinsulin can get misfolded, and then it's not cleaved into insulin and C-peptide, and so elevated proinsulin to C-peptide levels indicate a beta cell that's under stress, okay? And so if we look, these graphs, HV is healthy volunteers. So if we looked at Fasting and meal stimulated, that's -1 and 90-minute. Proinsulin to C-peptide ratios, and again here, lower is better. In healthy volunteers or TPIAT, we saw this elevated in TPIAT. And so we thought, well, that's probably a hyperglycemia response, and it is. So hyperglycemia stresses these islets. Turns out so does obesity, even to some extent if your glucoses are well controlled, so not strictly dictated by hyperglycemia. So does having low islet mass, not as many islets there to begin with. I think that this might translate over to pancreatitis as well. We just haven't really studied it in pancreatitis yet. We've also seen that early proinsulin to C-peptide ratios, which is shown here at 3 months, predict insulin dependence or independence at 1 year. So even as an early marker, those cells that are more stressed, those patients are less likely to come off insulin. Granted, this is in a much smaller patient population. So I want to spend the last couple minutes telling you about alpha cell function, gut hormones, other stuff related to TPIAT, because we don't talk about how alpha cells work. Alpha cells turn out to be kind of tough to test. You know, their main function that we recognize is that they produce a lot of glucagon in response to hypoglycemia. That means to test them, you have to make someone hypoglycemic. So you put them in this controlled setting where you do a clamp, and you drop them from euglycemia to 70 to 60 to 50, and you watch the hormone response. So we did this a number of years ago with an endocrinologist, Paul Robertson, who was he's retired now, but very well known in the field, and looked at healthy controls, which are in yellow, who have this nice glucagon response as you get down to 50. And most of our TPIAT patients who were insulin independent but had islets in the liver did not have this response. Kind of this funny observation here that if we put islets outside the liver, we just happen to have patients who had islets outside the liver. In this study, they actually had a more robust, so they had liver islets in a second site and had this robust glucagon response. I don't know that that's borne out in our more recent data, but it does raise the question as to whether islet site might affect how our alpha cells are working, whether they're living in the liver or somewhere else. More recently, Dr. Ladd is working on this analysis with us. We've looked at this in a more recent cohort of patients compared to healthy volunteers. And with this graph up on top, TPIAT is here, healthy volunteers are the red, and you see this really nice, robust response in healthy volunteers, whereas the TPIAT remain a little bit more flat. Now here the color scheme is different. These are just TPIAT, but this is off insulin and this is on insulin. So one of the things you see is if you're off insulin, you have some functioning beta cells, you do have a better glucagon response than if you're someone who's on insulin. So the amount of beta cell function you have, because there is a beta cell alpha cell communication, makes a difference in how much alpha cell function you have. But the other thing that we see in these patients is they do not have normal incretin hormones. That's probably not a function of the islet transplant, that's a function of the pancreatectomy, where we take out the duodenum and we do a Roux-en-Y reanastomosis, and they actually have exaggerated GLP-1. I didn't box that here, but it's right here. These were patients who were on sitagliptin or placebo as part of a clinical trial, so not surprisingly, if they were on sitagliptin, this was hugely upregulated, but there was even a trend towards increased GLP-1 in the ones on placebo, and later data actually showed a significant difference there. So we do see increased GLP-1, which is also graphed up here. And we see reduced GIP. That's because that comes primarily from the duodenum, and we take the duodenum out. So this might have some therapeutic implications. But I want to highlight this GLP-1 response that increases after surgery, because that is a mechanism in bariatric surgery that has been proposed to potentially contribute to post-bariatric surgery hypoglycemia. So I think in our patient population, when we talk about hypoglycemia, some people have talked about this deficient glucagon I just showed you, but I think that that might actually pertain more to the absorption and the incretin process that's going on in the gut. So what am I talking about when I talk about hypoglycemia? Well, we do see these patients who are off insulin therapy, no insulin, and they're coming back to clinic saying, I'm having hypoglycemia. A lot of times that's mild. It might be 60s, and I'm not sure, is that actually concerning or not? Are we just picking it up because they're monitoring? But sometimes I have these patients come back and they're dropping to the 20s and 30s. That's rare, but we see that. So it can be very significant. And 7% of these patients off insulin in a recent analysis that we're working on actually reported severe hypoglycemic episodes. And so we think that this is driven by the altered GI physiology and maybe the glucagon. It seems to be post-meal and exercise-induced very commonly, less so fasting. And we go through these steps, yet to be determined how well these work, but hypoglycemia diet and CGM monitoring are probably what we do for everyone. But we try drug therapies like acarbose and diazoxide and mini glucagon dosing to try to treat this. So with that, I will just wrap up and say, I hope that you took home from this that most patients do have islet graft function, even long-term after TPIAT from those transplanted islets in the liver, even if they're not off insulin. But in those 20 to 30% of cases where we do achieve insulin independence in the first few years, they do lose insulin independence slowly over time, albeit with some people still off insulin 10 to 15 years later, probably driven by stress on these islets. And then we do have some of these challenges that remain to be better addressed, like hypoglycemia, alpha cell function. I think more work still to be done in that area. So with that, I will conclude. Thank you.
We're open for questions. Well, Dr. Ladd joins us up here. I have a common question combo for you, Melina. We clearly haven't found the ideal spot where to put these islets, right? We think the liver is the best, but it's clearly not, right? Like we're losing over time. Any thoughts on, and I know you've worked on this before, on making this disrupted environment that we created more stable for these islets?
We don't know. No site that we've tested has been better than the liver. Despite the data I showed you with the glucagon, the islet cell survival is not better in any other site that's been tested. So I think Cole, one of our trainees, is going to be presenting on a study where we actually tried to do omental site transplants. They did not perform better, and they probably performed worse. But they need to be vascularized. I think the answer to your question is reduced inflammation, improved vascularization are probably the keys.
Just to piggyback on that, we have a lack of a data on the nature of the liver in every liver we put in, because every liver are different. Being a transplant surgeon, like we see the liver and we look at them different microscopically, and also amount of the fat, macrovascular, like a grade of the inflammation, and the inflammatory reaction to a reperfusion is also different. And I think that's very hard to capture. And that's why they all react so differently. Do you have any data in the lift on the liver biopsies, like 2 years, 3 years down the line on any of these patients?
So I don't have so we have some post-transplant liver biopsies, but they're not done in a way to have, there's very few of them, and they're done in people who specifically have liver problems, right? So I can't really give you a good answer. We have TPIAT liver biopsies, though, in a number of patients. We had a period of time where surgeons were doing this routinely intraoperatively, and do see a bit of a relationship between islet graft function and steatosis that's present before. It's not good. So steatosis before is not good.
Go ahead. You can take this.
I can just shout.
Go ahead. Here you go.
Thank you. Sorry. It's Minoti from Sydney. I have a question for both of you, and maybe out of ignorance. So I've heard that the quality of the islets is important in terms of eventual function. And I'm wondering, and I know that usually the transplant is done while the patient is on the table, right? With an open laparotomy. But is there a place for actually trying to optimize the quality of these islets? So you close the patient up, but then give them the islets when they're in a really optimally good condition later on. And the other thing is, just like freezing sperm or eggs, for example, can these be frozen down and maybe recultured? And if you wanted to retransplant them, could you do that?
Yeah, I think that's an interesting question, probably more that an islet biologist could speak to, but I know that there are new methods being developed to help kind of maintain the quality of those islets and the quantity long term.
I think if we had a way to do that, that would be ideal. It just is a lack of way to do that. So right now, if we culture islets, which we don't routinely do because it would require an IND in the US to culture islets overnight, but if we did, we would lose some islets along the way of culturing it anyway, so.
But you'd have to have quantities.
Well, not necessarily right now, but I think we would have to, it would have to involve some treatment paradigm with that culture period as well, yeah.
Okay, question. So I was looking at your data, the glucagon data, and it looked like the fasting glucagon was higher, and then it doesn't, and then it doesn't go down enough, and then doesn't come up enough. Is that accurate?
It's accurate. Actually, Jen could take this one too. So we it's a high. I didn't have a chance to explain the technology of this, but it's a high dose insulin infusion, right? And so it's the suppression from euglycemia to 70 is actually from the insulin infusion itself. So it's iatrogenically introduced, and so we're actually looking at the change from 70s up to 50s in that particular study. That's why.
So that it reminds me of cystic fibrosis is all I'm going to say for that one. And then the other thing with CF that I just wanted to throw out there based on what you guys were talking about is that we have seen severe hypoglycemia spontaneously, but only after ETI.
Hi, Mikko Seinto at UCLA. I'm just following Papa Minoti had a great idea here. So we have, coming from the experimental side, we have chronic pancreatitis mouse models with complete progressive destruction of the pancreas. So at the end, you know what happens with the islets. They improve. They're much better, as opposed to the human situation. So this actually leads me to believe that you could pre-treat the patient and improve islet function in situ before surgery, which is a little variation on your theme instead of. And then this comes to my question. So what's the status of chemical pancreatectomy, which was hyped, in the news for a year back? And so I'm sure you have a strong opinion on that.
Yeah.
So what is
well,
it?
No, it's still in research. It's not been used in people. I think I don't know. I have some skepticism about whether it truly wouldn't harm islets in people, whether it would truly,
Because that improves islet function also in situ.
It does. But I don't know. I'm skeptical that it truly would. But the thing with the mice, I mean, that is interesting. But mouse islets are always so different from human islets. The type 1 diabetes work, right, would show that as well. So I don't know if I'd hang my hat on the mouse.
Just the idea that you could pre-treat patients which might improve islet function before surgery.
Yeah, I think that concept is wonderful.
Excellent. I think we are over time now for a couple of minutes, so we'll conclude this session. Thank you.
Right away, actually, inpatient and the kids. Yeah.
So, there. Okay.
Hi, nice to meet you. Yeah.
So how do you want to?
Maybe I can just. I can release fork and then you can finish it. Good afternoon, everyone. I'm Dr. John George. I serve as the research director at Advent Health Digestive Health Institute in Orlando, and I am a clinical pancreatologist within our Center for Interventional Endoscopy. It is my pleasure to chair this session on Acinar-Islet cell compartment interactions with my co-chair, Bomi Lee from Stanford University. Over the next 1 hour, we'll explore how the exocrine and endocrine pancreas communicate starting from developmental biology to stellate cell crosstalk and overall regenerative signaling. These talks convey the translational bridge between exocrine and endocrine pancreas and overall also on pancreatic regeneration.
So our first speaker is Dr. Manami Hara. She's a research professor at the University of Chicago. Her research focuses on the development of the pancreas and the pathogenesis of the diabetes. Welcome.
Thanks for organizers for giving me this opportunity. So we just proposed a new model of pancreatic blood flow and then upset many people in the field, particularly islet biologists and islet physiologists. So let's see why. And so pancreas is a really unique that consisting of exocrine and endocrine islets. And nobody knows why, but it's one organ. But somehow, as you all know really well, somewhat pancreas has been studied by two different scientific communities, and patients have been treated by physicians in two different medical principles. And so I think it all stems from the prevalent concept that islets are a totally independent structure within 98% of exocrine pancreas, and then it receives a separate blood supplies, out of the all the surrounding exocrine tissues. So what if they have a common blood supply? Do we see pancreas differently? So this is really conventional view of islet, the blood supplies. The first proposed in 1932, and at the time they, this person used cardiac perfusion of ink and even tissue clearing. So then and there, these are really really breakthrough technologies, and this model suggests that every individual islet have distinct blood supplies, so arterial blood supplies. Then, so even now, so islets are considered isolated microorgans independent from the exocrine pancreas. So the arterial blood go through the islet and it drains from the venules. It's just one-way traffic. So is the islet really an enclosed structure? So we first studied intravital mouse islet imaging of mouse islet microcirculation using MIP-GFP mice, in which beta cells are, this is a transgenic mice, and the beta cells are tagged with GFP under the control of mouse insulin 1 promoter. So all the beta cells show up in green. And RBC are the externally di-eye labeled and then injected through the retroorbitary. So this is a really large islet, and it's showing the beta cells in green and the di-eye labeled RBC. Then here we're showing only di-eye labeled RBCs. Now these individual RBC are digitally captured by using Imaris image software. And once you do that, you can do anything you like. And this is called dragon tail tracing. And then if you let them go, and then the tails are accumulated, and then it will show the capillary network within the islet. So you can see the direction of the flow. And then we quantified, so from endocrine to exocrine in pink, and from exocrine to endocrine in blue. So the ratio is about, after examining 42 islets, it's about 1:1. And then now we can count exactly how many these interface capillary there. So at this level of resolution, you have to use the machine learning functions. And then here it shows the islet diameters. And so the segment counts are plotted against surface area. And for example, if the islet is 90 microns in diameter, then segment count is 35. If it's 200 microns, and then 155. So what we really want to emphasize is that to study the network structure like vasculature, it should be done in 3D, because in 2D, there are just short lines and the dots. So this is a human islet, and then we are showing completely integrated microcirculation between exocrine and endocrine parts. So this is an islet stained with pan-endocrine cell marker, and this is the same panel showing just vasculature. So integration is really at its entirety. And then here, islets are made transparent. So the next question is, do the individual islet receive the dedicated arterial blood supply that was suggested? And then, as it often happens, like a new technology or a new reagent really advances the science. And here, now we got so-called alpha estimates. This is alpha, a smooth muscle actin. So this labels large blood vessels like artery and veins, and also arterial. So as you can see, this is the endothelial cells expressing CD31, and the smooth muscles are really covered. So you can tell these are arterioles. And then this one looks like in a really conventional islets receiving feeding arterioles, but you can see there's a lot without any arterial contact. But it is, but 2D view is really deceiving sometimes, so you want to be careful. And then here's a large capture of the one lobe of the pancreas, human pancreas. And then we made it, the render, 3D rendered, so that you can see each structure clearly. And then now, what was really striking or surprising to me was that these capillaries are really directly branched out from the trunk of the arterioles. And then some islets are really close to the arteriole, but some are really not. And it's been, I've been always thinking capillaries are really singly just branched out, from the arteriole, like a one-to-one kind of relationship. But here, it's just this arteriole just passing through the islet. And then this islet is just kind of situated here. But this one, you can see like all the signals from arterioles, they will receive directly from this one and also this one. And this is from the seminal paper published in 1982 by Dr. Susan Bottowier and Ouch. And then, so we just found a really similar, structure. And the difference is they called this one as small arteriole. So small arterioles are branched out of larger arteriole. So still every single islet receive really dedicated feeding arterioles. The only difference here is, again, the markers. We do have markers now for arterioles, so that's really helps us. But actually, I believe we're seeing exactly the same thing. And so such direct capillary branching out of the trunk of arteriole is not in the textbook. And then I kind of, convinced myself, sort of, I didn't see this because I didn't want to really embarrass myself. But So this is the University of Chicago's bookstore, and these are called red bark, and they only bloom in April and May. And then I've been really passing through this structure, these trees every single day, and then I just admired every spring, but that was it. Until one day, I just find something really caught my eyes, that these flowers are called cauliflower, and the flowers can really bloom out directly from the trunk. So that was really wow moment to me. And then so what we think is not every single islet are got the distinct blood supply, arterial blood supply, but it's more of a regional. And within the region, so there's arterial contact, islets with arterial contact or without contact. So there must be some gradient in the signal transduction. So there's no stereotypic islet response as suggested before. And then now, seriously, there's many islets, so with or without contact. So we measured the shortest distance between islets and arterioles in 3D. So contacted one should give a 0 distance, and then if there's no contact, that should be positive. And then now there's obviously islet size differences. So contact ones are in blue, the cyan, and the no contact ones are shown in red. So probably just by eyes, you can see contact ones are larger. So we did quantify, and they threw out 6 species. And then the contact one islets are basically larger than non-contact one. Of course, there's a significant overlap. And then now pancreatic blood regional flow. For us, the in vitro work, the use in isolated islets really works. And then moreover, the slice, the experiment, live slice experiment, really, they give a really nice response. So I think this is really the supportive evidence for the regional blood flow, although, so these slice people, like this model because it makes sense to them, but then these slice experiments are also really, they're still having a hard time because, again, there's no direction of their flow, blood flow. So currently, we're working on more regional analysis of this islet distribution. Finally, so this series of studies has been started by Mike Dibala in 2020, followed by Adam and Khalil, and Alex and Frank, our most recent lab members, and they just got the poster award recently. Thank you for your attention.
Thank you. Next, I would like to introduce Dr. Minote Apte. She is visiting from Sydney. She is an internationally acknowledged and recognized key opinion leader in the field of pancreatic stellate cells and pancreatic fibrosis. She'll be presenting on the role of stellate cell in pancreatic function and disease.
Thank you very much, John. I don't know why I call you John. Sorry, thank you, and good afternoon to Bomi and yourself, and thank you very much for the invitation, Melina, and also the organizing committee for this opportunity to discuss some of this topic with you. But I was given this title by Melina, Role of Pancreatic Stellate Cells in Health and Disease, but the issue is that over 2.5 decades since we first isolated and characterized these cells, there's been an explosion of research activity in the field, so there's no way I can cover everything we know so far about stellate cells in 15 minutes. So I thought I might just focus on PSC-islet interactions because that's the theme of this symposium anyway. I just want to first acknowledge the people in my group, particularly some of those whose work I'll be sharing with you, but also our collaborators around the world and within Australia, and a particular shout out to Shaunak Majumdar and Suresh Chari for the work that I'll be describing just now. And of course, our funding bodies. So many years ago, we were able to isolate and characterize these cells, and you can see these, you can identify them by a number of selective markers. Here we've used desmin, which is a cytoskeletal protein. You can see these desmin-positive cells with their long cytoplasmic processes along the basolateral aspects of acinar cells. And in culture, this is what they look like, with a lot of lipid droplets in the cytoplasm, and these lipid droplets contain vitamin A. And in fact, storage of vitamin A is what distinguishes these cells from fibroblasts. About a decade and a half after that, stellate cells were also found around islets. Sorry. And here they've used another marker called glial fibrillary acidic protein, or GFAP, and you can see these, sorry, go back. You can see these GFAP, I keep doing this, sorry. You can see these GFAP positive cells in and around the islets. In our lab, in the diseased pancreas, we found alpha smooth muscle actin positive stellate cells, which are a feature of activated stellate cells. Now, in quiescence, during health, of course, these cells store vitamin A, and they also have a number of functions in terms of regulating homeostasis in the pancreas. So they regulate ECM turnover because they secrete ECM proteins, as well as the metalloproteinases that degrade the ECM proteins. They're shown to have an innate immune function because they express toll-like receptors and are also capable of phagocytosis. There's no role yet in acquired immunity, but we had previously shown that they might be intermediary cells for CCK-mediated acinar enzyme secretion. And there's a few studies that have shown that these cells may have a progenitor or a stem cell function. During disease, of course, they are activated into a myofibroblast-like phenotype. The first thing that seems to happen is they lose their vitamin A stores, and they get positive expression of alpha smooth muscle actin, including there's a number of other functions that I've listed there that change when the cells get activated. Many different activating factors have been identified. Many different signaling pathways that mediate this activation have been identified. And interestingly, there are at least 3 signaling pathways that have been identified that mediate the reversal of the activated phenotype to the quiescent phenotype. And this is being now used in a way for clinical trials, at least in pancreatic cancer. And some of these signaling pathways include PPAR gamma agonists, all-trans-retinoic acid, and the vitamin D receptor ligand. So we know that in chronic pancreatitis, we've heard this before today, that the islets are impacted, and there is a lot of fibrosis around the islets. And you can see this Cyrus red stain, which shows the collagen in and around the islets, and this is associated with alpha smooth muscle actin positivity in the stellate cells, and this is a section from a human chronic pancreatitis section. But we know that activated stellate cells act directly on mouse beta cells, so certainly they can decrease insulin secretion, but they also cause apoptosis of the beta cells, so both together can impair islet function such that it leads to hyperglycemia. Now, hyperglycemia, in turn, can actually aggravate the detrimental effects of stellate cells on mouse beta cells. So this is like a feed-forward loop. And interestingly, GLP-1 agonists can reverse this hyperglycemia-induced PSC impairment of insulin secretion by mouse beta cells. So the whole thing is a connection between stellate cell activation and glucose homeostasis. So our interest in diabetes and pancreatic cancer actually stemmed from work that Suresh has described this morning, and he was the first person who described this population of patients that were termed as pancreatic cancer-related diabetes. So these are the patients you've heard about. They have new onset diabetes, and within 3 to 5 years, they they have or are diagnosed with pancreatic cancer. Now, the earliest lesions of pancreatic cancer are pancreatic intraepithelial neoplasms, and this is what everyone knows. But what we were intrigued to find was that we could find activated pancreatic stellate cells around these earliest lesions. So in the human pancreas, as well as in the mouse KPC model, very early on, we could find these alpha smooth muscle actin positive cells around the pannins, in and around the pannins, as well as around this adjacent islet that you can see. So we've shown before, and many others have corroborated the fact that there is a close interaction between stellate cells and established cancer cells. But what we are postulating for this subset of patients that come with diabetes, and then they have 3 years before they develop cancer. So this is a wonderful window of opportunity that Suresh and others have mentioned, that if we understand the pathogenesis of this process, it may be useful for new targets for therapy, or at least even biomarkers. So that's what we are aiming to do. And the hypothesis is that pancreatic stellate cells interact closely with pannins. When they do that, they secrete factors that are carried by exosomes. And these exosomes can travel. We've just had a wonderful talk about circulation. I was really interested. And they could probably travel through the circulation to islet cells, to the islet PSCs, which in turn can become activated, and then they would exert their inhibitory function on beta cells. They could possibly also travel to a more distant site, such as the liver, or even the muscles or adipose tissue, where they might impair insulin signaling and therefore cause insulin resistance. So the combination of a decrease in beta cell function and an increase in insulin resistance could lead to hyperglycemia and diabetes, which in turn would activate pancreatic stellate cells and then cause cancer progression. So to actually look at this first component of our hypothesis, we were using a mouse model of KRAS mutated mice that were fed a high fructose diet. So this is work that has just been completed by our PhD student in our group, where we used this model because we didn't want to have a high fat diet to cause cancer progression. We didn't want the confounding effects of obesity. So we used a high fructose diet in these mice. And at week 0, we tested their baseline glucose levels. At weeks 8 and 16, we tested glucose tolerance in them, and then collected their pancreas at week 16 to do histological and other analyses. And what we were able to show is, and because of time constraints, I'm going to show very, very snippets of data of all of these concepts that I'm showing you. So what we were able to show is certainly at weeks 8 and 16, the high fructose diet animals showed impaired glucose tolerance. This was associated with a rapid progression of pannins to overt cancer. So these are just representative images of the various grades of pannins. But if you could focus on this pie chart, you can see that in the high fructose diet fed animals, you had significantly higher proportion of pannins 2 and 3. And in fact, the whole section was covered more with the pannins in these mice than the control mice. And this was associated with stellate cell activation, and we quantitated that morphometry, and you can see this the higher expression of alpha smooth muscle actin in the KC high fructose diet mice. So in a sense, that component of our postulate with hyperglycemia leading to stellate cell activation and cancer progression, I think has some support here with these data. What about the other one? This exercise about the effects of exosome on the islet cells, stellate cells, and beta cell function. So to do that, we used either KPC cells, the mouse cancer cells, or human cancer cells cultured alone, PSCs from both mouse and humans cultured alone, and the relevant cells put together in co-culture. Because remember, I said that we are looking at the interactions between the two cell types. So we collected exosomes from that, and then we characterized the exosomes and used those for our further experiments. So this is a study led by a very talented postdoc in my group, Chamini, and she's looked at the effect of exosomes on insulin secretion by mouse beta cells. And what we found was that both the exosomes derived from the culture, the single cultures alone, as well as the co-cultures, significantly reduced insulin secretion by mouse beta cells when compared to an sort of unrelated or irrelevant acinar-derived exosomes. And this was in the face of no decrease in insulin content of the beta cells. So it seems like synthesis wasn't affected, but secretion was. But what was even more exciting for us was the pan-in situation. So when Chamini used either p53 cells alone or KRAS mutated cells alone in culture alone or together with stellate cells, again, we saw a significant decrease in insulin secretion by mouse beta cells. What about the other pathway, the ones on the effects on the peripheral cells? Again, I'm only going to limit myself to hepatocytes and very quick overview here because of time. So we all know that the insulin signaling pathway consists of insulin binding to its receptor, which is denoted as IR here, which activates insulin receptor substrate and PR3 kinase. This phosphorylates AKT, which has a number of functions in the cell. But AKT is also responsible for regulating the translocation of glucose transporter 2 to the cell membrane. And this GLUT2 is, of course, responsible for letting glucose arrive into the cell. So here, our PhD student Rohit, whom I mentioned before, has looked at a number of factors. I'm only showing you a few of these. So insulin receptor substrate, for example, in the pan-in plus PSC exosomes was significantly inhibited in its expression, as was its phosphorylation, as was the GLUT2 expression. So certainly, these exosomes are doing something peripherally to impair insulin signaling and have a role in glucose disruption. So the question then was, what is it in the exosomes that is mediating all these effects that we are seeing? And of course, now we've gone down the omics path, which using proteomics, lipidomics, and sequencing to look at what the exosomes carry. Again, very, very brief snippets of data here. There's too much to cover. But again, with Chamini's work, we found that there were at least 15 proteins that were significantly differentially expressed in the co-culture-derived exosomes compared to the exosomes from the cells cultured alone. And when we did a functional enrichment analysis of this, we found that the co-culture-derived exosomes had the enrichment of certain proteins that were involved in glucose metabolism, but also some others such as collagen formation and so on. So what we did was we looked at the most differentially regulated or differentially expressed proteins and then shortlisted about 7 of them, which we found in the literature have had something to do either with glucose homeostasis or with cancer progression or both. And so these are the 7 that I've listed there. But basically, in terms of clinical relevance, we also found that some of these proteins are definitely highly expressed in pancreatic cancer patients. So this is bioinformatics of the TCGA data set. And these proteins were also, the high expression was correlated with poorer survival. So there's something that these proteins are certainly relevant to us when we study PCRD. The next is lipidomics. This is really hot off the press. Basically, where we found that the co-culture-derived exosomes had a completely different lipid profile compared to the exosomes that were coming from the cancer cells alone. Interestingly, there was just one lipid that is really highly expressed by volcano plot analysis, and you can see this here. This is called the lactose ceramide, and not much is known about it, but apparently it has been implicated in tumor progression in other cancers and also in insulin resistance. So this is something that we want to follow up. Coming to RNA-seq analysis, so this is again work from one of our PhD students, Helen, who has a poster as well as an oral presentation here at the APA. So there were many different RNAs that were found, both protein coding and non-coding in all the exosomes that were studied. Again, to save time, I'm just telling you that we selected 3 because of what we know about them in literature. The first one is phosphatidylinositol binding clathrin assembly protein. This is a mouthful, PICAM, and it's interestingly has a role in Alzheimer's disease, but has also been shown in adipocytes to regulate the transport of glucose transporter 4, so something to do with glucose metabolism. The other one is PRKAG2, and the third one is a non-coding small nucleolar RNA. Now, just in terms of PICAM, and again, just one bit of data. So what Helen found was that in the exosomes derived from the cells cultured alone, the PSC exosomes had a higher expression of PICAM than the cancer cell exosome. Interestingly, when we were co-cultured the two cell types, the co-culture derived exosomes seemed to follow the PSC path rather than the cancer cell path. So again, you had high expression of PICAM in the co-culture derived exosomes. And this seemed true for a number of other RNAs that I haven't shown you here. But also, the more important thing is that we saw a similar pattern in the human situation. So when you had cancer-associated human PSCs cultured alone, they had a higher expression than the ASPC1 cancer cells alone. In co-culture, again, the co-culture derived exosomes from the human cells had higher PICAM than the cancer cells alone. And then for the in vivo significance or relevance, we looked at the mouse plasma. Remember that mouse model that I showed you with the high fructose diet. And in the plasma of those mice, we found upregulated, these are plasma exosomes from these mice, we found upregulated PICAM in the high fructose diet fed mice compared to the KC control. So again, this was of interest to us, and as for clinical relevance, PICAM expression has been shown to be associated with poorer survival in the data set that we looked at in the TCGA data set. So now, of course, we want to go and do some downstream validation. So Helen has only just started this work, and what we've got here is that when she inhibited the synthesis of PICAM using siRNA in the two individual cell types, then brought those cells together to look at what the co-culture derived exosomes had, she certainly found that there was very little PICAM in the co-culture derived exosomes. And then, if you remember, I have shown you that insulin secretion was significantly reduced in co-culture derived exosomes, and this interestingly was reversed when we inhibited the synthesis of PICAM, or inhibited the amount of exosome PICAM in the co-culture derived exosome. So this is again something that needs to be followed up in more detail, but we think this is really interesting because it actually gives us a way to maybe this is a pathogenic factor that is mediating pancreatic cancer related diabetes. The other thing then, and this is, I'm only got a couple of slides here, but the other thing that we were interested in doing this work was to see whether these factors that we've shortlisted could be used as potential biomarkers for the early diagnosis of pancreatic cancer. And so to do that, we need to look at patient samples, and these are the samples that Shaunak has kindly provided us from the Mayo Clinic. A limited number of samples, but anyway. So what we've got is that plasma from pancreatic cancer patients with recent onset diabetes, with long-standing diabetes, cancer patients without diabetes, and then diabetics without pancreatic cancer as control. There's some really intriguing data that we've got, but I don't want to steal Helen's thunder because she's presenting this as an oral presentation. It's her first oral presentation at the APA. So I would urge everyone to attend it if you're interested, but that's why we think that we have a biomarker that seems very, very interesting. And that's Helen's talk on Friday in the morning. So, in summary, very quickly, resident cells of exocrine and endocrine pancreas, the stellate cells are. In normal pancreas, many different roles in ECM turnover, innate immunity, and so on. In the diseased pancreas, certainly they're activated both in the exocrine and endocrine system and have many different roles in inflammation and cancer progression. The activated PSCs do induce islet cell dysfunction, and as I've shown you, exosomes derived from the interactions between the stellate cells and cancer cells or pannins may play a critical role in PCRD, and for us, our interest is to now characterize the specific exosomal cargo that will allow us to identify either novel therapeutic targets or biomarkers for early diagnosis. So I might end there, and thank you very much.
Thank you. Our next speaker is Dr. Jordan Wright. He's an endocrinologist and islet biologist at Vanderbilt University Medical Center. He'll be talking about effect of insulin Acinar development, lessons from neonatal diabetes.
I don't need those. Great. I'm going to hold this. Great. Thank you for the opportunity to present. This has been really exciting. Oh, is that? Great. This has been really exciting for me. Usually when I present this data, it's in a diabetes focus group, shoehorned in as miscellaneous, so it's nice to be focusing on the exocrine tissue. Oops, wrong button. All right, so as a brief outline of where I'll be going today, I'll start by talking about what we know about pancreas volume in clinical and preclinical type 1 diabetes. Then the structural changes that we see in the pancreas in type 1 diabetes, and then trying to look at mechanisms in humans of what can be driving these changes. I'll emphasize all these studies are in humans. There's been a lot of talk about difference between mouse and humans, so I won't discuss that any further, but we try to move as much as we can from animal models into human models. So very quick review of progression of type 1 diabetes. Everyone starts with some ill-defined functional beta cell mass. They have some degree of genetic or environmental risk that starts a triggering event that leads to the autoimmune process. When we can first detect that autoimmune process, we call that stage 1. That's by measuring autoantibodies. In stage 2, we can still measure those antibodies, but they've become dysglycemic, not yet clinically diabetic. And when you would make the clinical diagnosis, that would be at stage 3. Through that process, you have a steadily declining beta cell mass. And I leave this to remind myself, as everyone here knows, the islets make up a tiny portion of the pancreas, usually around 2% of the total pancreas volume. So we as endocrinologists very much focus on the islets in diabetes for understandable reasons. There's been less focus on the exocrine tissue, but we know there are changes in the exocrine pancreas in type 1. Examples include, these are numbers taken from a meta-analysis a few years ago, but you can see as many as 20% of people with type 1 diabetes have what would be classified as severe exocrine insufficiency, also elevated in type 2 as well. We also see reduced pancreas size. So this is a study from Martha Campbell Thompson's group a few years ago looking at pancreas weight in the NPOD group. So these are donors, pancreatic organ donors. And again, when you look at the pancreas size compared in type 1 donors compared to non-diabetic donors or compared to type 2 diabetic donors, you have significantly reduced pancreas weight. Other changes, there's already, everyone here knows about the increased risk of adenocarcinoma. There's also known immune cell infiltrate and fibrosis in the pancreas. So we became really interested in why does the pancreas size change so much in type 1 diabetes when the islet mass is only at 2%, 2% of the total mass, but we see a 40% reduction in the size of the organ. To start studying this, we formed this multi-center assessment of the pancreas in type 1 diabetes, largely led by Jack Verosco, who I think presented last year here. So you may have seen some versions of this data. We developed a standardized MRI protocol that is fast. It only takes 25 seconds, and it doesn't require contrast, so we could recruit children and adults to participate in this study. And here are examples of the images we're able to obtain and identify the pancreas on our MRI images. So this is a study we published in 2019. Here I'm reminding you of this progression that we see with color coding matching what we see here. But I'm reporting the pancreas volume index. So that is pancreas volume on MRI normalized to body weight. And when we recruited individuals that had just recently been diagnosed with type 1 diabetes, so this is stage 3 of disease, and just within 100 days of diagnosis and compared their pancreas volume with people with autoantibodies or with controls, we see this marked reduction in their pancreas volume index, even at the first diagnosis of the disease. At the same time we published that, Martha Campbell Thompson published a similar study. They report relative pancreas volume normalized to BMI instead of body weight, but it's similar. And they saw similar results where pancreas volume is markedly reduced between the at diabetes diagnosis. Also, intermediate reduction in pancreas volume in autoantibody positive individuals, and they took it a step further and looked at first-degree relatives. So these are people without autoantibodies, but with that increased genetic risk of disease because they're related to individuals type 1. And they also had a reduction in pancreas volume. So we became more interested in what is happening as someone goes from here to there. So we designed a longitudinal study working with the people at Type 1 Diabetes TrialNet, identifying individuals with positive autoantibodies and then monitoring them every 6 to 12 months by MRI to see what happens to pancreas as they develop clinical diabetes. During the study, we had 54 non-progressors, 11 people that progressed to stage 3 diabetes. So here I'm showing a plot, the pancreas volume index again. Sorry if the wording's small, but this is looking at pancreas volume index at study entry, and then breaking it down by what stage they reached during the 5-year follow-up. So these are people that stayed in stage 1 throughout the study. These are people that reached stage 2, and these are people that reached stage 3. And you can see at study entry, so before any of them have clinical diabetes, the people who would go on to develop clinical diabetes already had a smaller pancreas in the stage 1 or 2 phase. So and this when we look at the longitudinal data and plot time 0 as the time they were diagnosed clinically, and look at the pancreas volume over time, you can see a decline in those approximately 3 years prior to clinical diagnosis. So they start smaller when they first enter the study and get smaller as they progress towards stage 3 disease. We still are really excited about the possibility that a whole pancreas image could help predict who is most likely to develop clinical disease, which could be useful for interventional trials and prognosis for the patients. So when you look at receiver operator curve analysis, so this is looking at sensitivity and specificity of our test. A perfect test, if you're not familiar with these plots, a perfectly specific, perfectly sensitive test would be a right angle here with an area curve of 1. A perfectly useless test would be a diagonal with an area under the curve of 0.5. So our test alone measured in pancreas volume index has an area under the curve of 0.76. When we compare that to current metabolic parameters that are used to do similar predictions, like the index 60 or the DPTRS score, it's about the same ability of prediction. When we combine our pancreas volume index with the DPTRS score, it brings up to a 91%, so pretty strong ability to predict which people are most likely to develop diabetes in the next couple of years. So, in summary, what do we know about pancreas volume in diabetes? We know that it's reduced very early, at least in stage 1, and it progressively declines as the person develops diabetes. And it's likely, or we are hopeful that it could be useful for prediction in clinical trials. So what other changes do we see associated with a loss in pancreas size? So this is a study we did. We're fortunate to get really well-preserved tissues, both from our biorepository, the NPOD, and the HPAP groups. This is performed by Adele Escaros in our lab, a clinical pathologist, but we were able to get organs from 20 donors with type 1 diabetes and 20 non-diabetic donors, age and sex matched. When you looked at the acinar and ductal changes throughout the pancreas, excuse me, and I apologize, the color on my plots didn't transfer over. But so if we look at ADM or Panin, these are relatively young donors, so we really didn't see much of either in these donors. What we did see strongly in our type 1 diabetic group is acinar atrophy, so smaller acini, fewer cells, and more connective tissue between the acini. It's already been reported that there's fibrosis in the type 1 pancreas. We have published on this before. This is from 2020. In this study published last year, we took it a step further, and we had really seen a difference in distribution of the fibrosis. So here we quantified the duct vessel fibrosis in type 1 diabetes and saw that in type 1, different from type 2, it's really a ductal vascular fibrosis that we saw most. Relevant to Manami's work, we also saw a lot of angiopathy, exocrine angiopathy in the type 1 pancreas. So scoring vessel wall thickness as a marker of angiopathy. We saw that in type 1 diabetes. There's a marked increase even in these young donors. So in summary of the other structural features, we see a lot of acinar atrophy, we see ductal and vascular fibrosis, and we see angiopathy in the type 1 pancreas. And now going on to studies in humans trying to get to mechanisms of what is driving, especially the pancreas size phenotype. Why might this be? Is it because of loss of islet acinotrophism? Is it during development, during adulthood? Or the alternate question is it because of autoimmunity inflammation in the type 1 pancreas? Initially to try to answer that, we tried to look for a mouse model. And we looked at NOD mice, the most common model of type 1. We looked at the DTR mouse, which expresses diphtheria toxin in beta cells specifically, or the Akita mouse, which expresses a mutant proinsulin. And in all cases, when we looked at the diabetic mice relative to their littermate controls, there was no difference in pancreas size no difference in pancreas size. So we do not think, at least the 3 models of insulin deficiency that we studied in mice replicates the human phenotype. So we turned back to humans again, trying to figure out how we can separate the autoimmunity aspect of type 1 diabetes from the insulin deficiency. There's a series of mutations in the insulin gene that are known to cause permanent neonatal diabetes. And so we thought this might be a good way to study humans that have insulin deficiency without autoimmunity. Working with Siri Greeley at Chicago, who helps run a monogenic diabetes database, he introduced us to a family that he had seen. We were fortunate they live in Nashville. It's a large family, and they were eager to be involved and eager to let us use their picture as well. So, but as you can see, so the father, he was diagnosed with diabetes when in his 20s. Didn't think of, there's no suspicion of monogenic diabetes until 3 of his 6 children were also diagnosed in infancy. And so they were eventually sequenced and found to have this G to R mutation in their insulin gene. So we recruited them for our imaging study, and here are example images and 3D reconstructions of their pancreases. On the left is an individual without diabetes in their family, on the right is one with. And when you quantify the pancreas volume index, you can see the marked difference in pancreas volume, similar in severity to what we see in unrelated type 1 diabetes. So we think this is good evidence. There's evidence in mice that insulin is trophic for acinar tissues. I think this is strong evidence that it is in humans as well, and that insulin deficiency alone is sufficient to cause the reduction in pancreas size that we see in type 1 diabetes. We did want to take it a step further, so that permanent neonatal diabetes is a severe insulin deficiency phenotype. MODY, maturity onset diabetes of youth, is a widely variable entity that you have range from very severe insulin deficiency to very mild. And so we thought we could get a better idea looking at more mild situations. So here I'm showing a model of a beta cell. Some of the MODYs are from transcription factors. There's insulin MODY, there's glucokinase, which is the most modest form that usually doesn't even require treatment. But working with colleagues at Chicago and Colorado, we were able to recruit good cohorts of several different types of MODY to look at pancreas size in these individuals as well. On the left, I'm showing pancreas volume index broken down by the individual MODY type, with the leftmost showing non-diabetic controls, the rightmost showing type 1. And you can see that most of the groups do not have significantly different pancreas volume compared to controls. There are two, the HNF1 beta and the permanent neonatal diabetes group, that do have reduction in pancreas volume. But interestingly, when we break it down by which of these individuals were requiring insulin therapy, there's a stronger difference. We see that those, regardless of genotype, those that require insulin therapy have a marked reduction in pancreas volume similar to what's seen in type 1 diabetes. So in summary of this portion, pancreas volume or reduction in pancreas volume correlates with insulin deficiency across multiple disease models. And based on the human monogenic diabetes studies, this reduction in pancreas volume occurs whether the diabetes is diagnosed in childhood or with adult onset. So in conclusion, type 1 diabetes, even though we all study the islets much more than the exocrine, it's really a disease of the whole pancreas. These changes occur very early in disease, possibly as early as we can detect the autoantibodies. We think insulin deficiency likely drives a lot of the pancreas size changes, but the relationship between type 1 diabetes progression and the other features, the fibrosis, the angiopathy, require further study. So that we always make sure we thank our donors and their families and participants in the studies, people in my lab and our collaborators that have really done this work, and I think my funders. So, thank you.
Thank you. Next, I would like to introduce Dr. Roger Liddell. Dr. Liddell is a physician, scientist, and professor of medicine at Duke University. He'll be talking about innervation of exocrine and endocrine pancreas.
Well, thanks very much. I appreciate the invitation to speak. I wanted to share with you some concepts that we are in the process of developing related to the gut-pancreas relationship. So I was a house officer with Rob Califf. We were interns and residents together. I went and became a gastroenterologist. He became a cardiologist, and he later became commissioner of the FDA. Now, half my lab works on intraendocrine cells, and the other half works on pancreas. But Rob knew that we were working on gut hormones, and when I saw him this summer, he said, GLPs are going to be the best-selling drugs in history. And he says, I always wondered why you worked on gut hormones, but now I know. So incretins, we've referred to a lot today. These are substances that are involved in glucose regulations. So the concept is that oral glucose stimulates greater insulin secretion than does IV glucose. So initially, it sounds a little bit counterintuitive, but this is due to the fact that incretins are released from the gut and account for about 50 to 70% of insulin response after a meal. And GIP, glucose-dependent insulinotropic peptide, and GLP-1 are gut hormones that potentiate glucose-stimulated insulin release. And it's GLP-1 and GIP that have been developed as therapeutic incretins for treating diabetes and obesity. Now, the problem is that mice lacking incretin hormones or their receptors exhibit mild glucose intolerance. Okay. However, mice lacking intraendocrine cells develop more severe diabetes. And the timing of incretin release from the gut, those levels in the blood, do not entirely match insulin secretion. So why might that be? So we study enteroendocrine cells, and these are sensory cells of the gut. And here, representative enteroendocrine cells are shown here in green. They arise in the crypt, migrate up the villus tip, and sloughed off and as they undergo apoptosis. So we typically think of hormone signaling as food or even microbes stimulating enteroendocrine cells that release hormone from the basolateral surface that migrate, diffuse into the blood. Alternatively, we know that enteroendocrine cells can release hormones that through a paracrine action can act on local enteric nerves. And either through a local paracrine action or through the blood, they can stimulate the vagus nerve. And this is why a number of gut hormones have been studied in relationship to regulating food intake and satiety. Well, a number of years ago, we started to study enteroendocrine cells using mouse models. And we used a CCK GFP mouse and a PYY GFP mouse. And we looked at those cells in tissue sections under the microscope. And what you see is here is an enteroendocrine cell shown in green, and up at the top is the apical surface, and it's open to the lumen of the gut, and it can be stimulated by food or microbes. And along the basolateral surface are the hormones that we showed in those cartoons. But what we saw in this image that was a little bit unusual was this little process right here. And when Rajmi Chandra, who was doing this work, showed me this image, I said, well, you know, that thing's not supposed to be there. That is not what the textbook describe as the way an enteroendocrine cell looks. These are either flask-shaped cells or elliptical cells, and that's not supposed to be there. But she looked again, again, and again. And here's an example of an enteroendocrine cell with a very long process extending off its basolateral surface. We've seen them coming off the sides, but they oftentimes will run along the basal layer of the intestinal epithelium. So at this point, we wanted to know what those things were, what they did, where they went. And Diego Borges joined the lab at that time, and he had done some electron microscopy in his PhD work, and so he joined the lab as a postdoctoral fellow, and he said, you know, I think we need to do some electron microscopy of these cells. Well, we talked to our local EM expert, and she thought this was going to be very difficult to do because normally when you do EM, you take a section of tissue and you look at it under the microscope, and what you see is what is under the microscope. But if you're looking for a particular cell with a particular process, that's going to be very hard to find under typical EM conditions. Well, about that time, a company had developed a process known as scanning electron microscopy. And it required dissecting this tissue with some orientation of what the anatomy might be so that we would guess that there would be an enteroendocrine cell there that we could find by EM. And this is what we saw. Let me see if I can go back. Is there any way we can run that video? Usually on my computer. Here we go, thanks. So this is basically a CT scan using an electron microscope. So there's a block of tissue. Then you can look at, there were 780 sections that were looked at here, and you gradually go through. Here are the nuclei, which are shown, and there's going to be one enteroendocrine cell there. That's going to be colored in yellow. It has microvilli at the tip. Here is the cell body, and here is this long basal process. And looking inside that we were able to identify within that basal process what looked like mitochondria. In the tip is packed with mitochondria, secretory vesicles, both large, dense core and clear secretory vesicles, and neurofilaments. Neurofilaments are the processes that make up the axons of nerves. And so we called that process, because it had these nerve-like properties, we called them neuropods. Now here's an example of an enteroendocrine cell. Here is an enteroendocrine cell, and you can see that here are enteric nerves that are stained here in red, and you see a nerve approaching that enteroendocrine cell. We also observed, by doing microarray analysis of the genes in an enriched population of enteroendocrine cells, that they express both presynaptic proteins and postsynaptic proteins. So here are some typical presynaptic proteins shown in red, as well as postsynaptic genes, suggesting that these cells have the ability to communicate with nerves, possibly through synaptic connections. The next experiment that was critical for this work was co-culturing enteroendocrine cells in nerves. Now, I didn't think this experiment would work, because enteroendocrine cells don't grow in culture. They're terminally differentiated, and as isolated single cells, they don't divide. However, they live long enough to do this experiment. So the experiment was to take a mouse. This was a mouse that expressed GFP and CCK cells. So here would be a CCK cell. And we took nerves, sensory nerves from the trigeminal ganglion. We've also done it from nodose ganglia. And those were labeled with dye so you could see them. And we saw this phenomenon. So here is the enteroendocrine cell, here's the nerve, and we watched with time-lapse photography what happened. So the enteroendocrine cell approached the nerve, and they withdrew, and it was connected. So what we see in vivo, well, what we see in tissue anyway, was reproduced in tissue culture. There's an attraction of enteroendocrine cells to nerves. And the third experiment is one that revealed what I hope to show you would be an interesting connection between the gut and the pancreas. And the idea was to use rabies virus. Now, rabies is a neurotropic virus, so if you get bitten by a rabid animal, the rabies will infect a nerve in the broken skin. And once it's in a nerve, it'll travel through synapses to another nerve and another nerve, eventually to the brain, and you would die of rabies. Now, rabies is comprised of the virus as well as a glycoprotein coat. And that glycoprotein coat is necessary for packaging the virus and allowing it to travel transsynaptically. So you can engineer a delta G rabies labeled with GFP, which is shown here, separate from the glycoprotein coat. Now, this rabies, this modified rabies, can infect a cell, but it can't travel transsynaptically. It can't go more than one synapse, okay? So the experiment was to take this modified rabies and put it in the lumen of the gut. And the experiment that I'm going to show you most immediately was done by an enema, so we were going to infect enteroendocrine cells in the colon. So we put rabies in the lumen of the gut with the idea that it would travel into an enteroendocrine cell based on the concept that enteroendocrine cells were like nerves and could be infected by rabies. It enters the enteroendocrine cell and turns that cell green. Now, if the experiment worked, what we would see would be green enteroendocrine cells. Well, that's exactly what we saw. So here are cells that are labeled green after installation of rabies GFP into the lumen of the gut. Here is one of those cells labeled green and also stained for the GI hormone marker PYY. And you can see that there is co-localization. So the rabies selectively infected enteroendocrine cells. Now, how could we use that to see if those enteroendocrine cells are connected to nerves? So we put rabies in the lumen of the gut again, but generated a mouse that expressed the glycoprotein coat in enteroendocrine cells. So here is the glycoprotein coat in this enteroendocrine cell. Rabies would infect the cell. It would be coated. The coat would then recombine with the virus, and doing so, turn the cell green, and that virus, if it was synaptically connected to a nerve, would turn the nerve green. Now, we had the idea that there was possibly a enteroendocrine cell to nerve connection, and we wanted to know where those nerves went. And Diego has established his own lab and has done a lot of work showing that there is a connection, a communication between the enteroendocrine cell and the vagus nerve. But we also know that these enteroendocrine cells lie in close proximity to enteric nerves that are not vagal neurons. So the idea is that there is a connection between enteroendocrine cells, enteric nerves, and might those nerves go to the pancreas, and could that be a way of communication between the gut and the pancreas, independent of incretin hormones? So that's our working hypothesis, and I'll show you just a little bit of data that supports that idea. So we have I've been working on trying to get images of a neural connection between the gut and the pancreas using tissue clearing, and Yune Choi, who is here and will be presenting a poster on this on Friday, will show more details. But here is the duodenum. Using neural staining, we see nerves extend from the duodenum into the pancreas and approaching the pancreatic islet. And we know that there is vigorous, robust neural innervation of the islet, but we can trace that nerve from the gut to the islet. Now, could we use our rabies tracing experiment to exploit the possibility that this may be a true enteroendocrine cell to gut connection? So again, we'll use monosynaptic tracing and see whether we can detect virus that we put in the lumen of the gut. This time we're giving it by gavage to animals to see whether we can see GFP appear in the islet. So if we see GFP staining in the islet, it must have come from this monosynaptic connection from an enteroendocrine cell infected by the rabies and appearing in the islet. And here's what we see. So here are pancreatic islets and we see green staining in the pancreas. You see these green fibers. Here is PGP 9.5 staining, which stains neurons, and we see co-localization of our GFP and our PGP 9.5, indicating that there is this communication between the gut and the islet. Now, Li Hua Ye was a fellow working with me before she set up her own lab, and before she left, She made the interesting observation that she had seen, she is a zebrafish endocrinologist, if you will, made the observation that there was a connection between, she saw nerve connections from the gut to the zebrafish islet. And we were actually talking last night, zebrafish only have a single islet, but the beauty of zebrafish is that they're transparent, you can see through them, and you can do some really interesting functional studies. And she's done some preliminary work showing that if you ablate enteroendocrine cells, or you will find that there is reduced neural innervation in the islet, and there are fewer beta cells in the islet with EEC ablation. Similarly, if you ablate the enteric nervous system in zebrafish, you can reduce islet cell activity by measuring, this is GCAMP fluorescence or calcium fluorescence, in mice that lack the enteric nervous system. So that's where we are. We think that there is and not only a gut to pancreas connection, but an enteroendocrine cell to islet connection that may be involved in regulating islet function. And we're in the process of conducting additional experiments using optogenetic techniques to exploit this system to see if we can manipulate functional islet activity. So this is the way we envision the work. We have the gut on one side and the pancreas on the other. Work has been supported by a number of very talented investigators who are shown here. And this is the way we envision it, the way it could be, if you will. And if you remember nothing else, maybe you'll remember this image. So thanks very much.
Thank you. Now this session is open to the discussion, so we would like to invite all the speakers to the stage. Okay, we have a lot of questions. I have a quick question to Dr. Hara. So you were showing the beautiful the vascularization and in the pancreas. I'm just wondering how those in the disease setting like diabetes and pancreatitis and pancreatic cancer, those vascularization is different changes in the disease setting?
Sorry, I didn't really get the point.
Yeah, those vascularization is changed by the disease.
Is it working? Okay. So we actually never had those tissues, but we actually studied on T2D. This is unpublished, but we have like 8 pairs, different ages, and then both men and women, and we are actually looking for differences in the T2D. So something, because diabetes is actually considered, particularly in a peripheral disease, it's a disease of hyperglycemia, so disease of vasculature, kind of naturally, and we did look for differences, but actually this, the vasculature were really retained in T2D, regardless of the duration, like 0 to 15 years of duration, so that was a surprise. But we think under the integrated vasculature, then insulin is really protecting. It's a growth factor, right? And so as long as the vasculature goes, it was really to remain. And so I think it's going to be another controversial and provocative result that we don't really want, but.
Okay, thank you.
Farzad Esney from Pittsburgh. So I have 2 questions to Dr. Wright. So one is that when you measure the volume of the pancreas, do you take into account the fibrosis? Because if yes, then maybe the effect is much. If not, maybe it's much larger. And the second question is, the effect of insulin, the insulin deficiency. So is it only the endogenous insulin, or so the exogenous insulin doesn't have any impact?
Yes, so the first question, do we take into account fibrosis on our imaging? There are ways to do that with the MRIs that we get. We haven't really seen much of a difference yet in those, whether that's a problem with the measurement or whether that's true. I don't know, but we haven't really seen the imaging fibrosis that we expected to see. And the other question, endogenous versus exogenous insulin. Yeah, so I really think it's the endogenous insulin because all of the people, at least in type 1, they are on insulin. Mm-hmm. And so I think it's endogenous insulin is necessary, probably at higher concentrations there locally than what is being given peripherally in diabetes. So.
All right, thank you.
And Suhail Hussain from Stanford. I have a similar comment, if not question. It's that Jason Bruce from the University of Manchester has published a few studies in mice, along with a different John Williams, someone more senior in the exocrine field from the University of Michigan. And what they showed was that insulin has acinar trophism, and in fact, through a series of calcium-mediated pathways and metabolic cues, somehow reduces inflammatory changes in response to pancreatitis. And what they did was they knocked out the insulin receptor selectively within the acinar cells. And I don't think that they saw any reduction in volume in the mice, and maybe for the same reasons, different models behave differently. But that would corroborate your findings. And I guess the question is, has there been any correlate to this with an insulin receptor deficiency? You showed insulin deficiency or a hypomorphic mutation.
Yeah, so I think it's a very interesting question. I don't know about the insulin receptor deficiency in humans, and so it's definitely worth looking at. As far as your comments about John Williams' work, so he was the director of the training grant I was on for my PhD. So I actually reached out to him for help on this paper, and they did not measure pancreas size in that. So that was my question for him. Thank you.
So I have a question, but first an interesting connection and comment. Li Huahie is somebody I know very well when she was in her PhD. It's Teresa Mastracci from Indiana University. And she actually did a zebrafish study where she knocked down insulin signaling in the developing zebrafish, and she saw a reduced pancreas size. So it's actually, it's a fish, not a human, but it would be interesting if it is an effect in utero, right, on pancreas development. My question sort of related to that is, have you been able to image PDX1 mutation containing patients or PTF1A, like something that would be a person with a mutation that affects how the pancreas develops?
We have not. We are open to imaging anyone that we can find. My prediction on those, my understanding is they've got really pancreatic agenesis, so we probably wouldn't see much.
So people with
the heads.
Yeah.
Okay. Yeah. If we can find them, I would love to. But I don't know them. Thank you.
So the talks were all brilliant. I'll ask two people questions. Dr. Wright, immune checkpoint inhibitors rarely can cause autoimmune diabetes, and your data suggests that in fact it's not the antibodies, it's the insulin, and ICI profiles may suggest the same, so you may want to look at that and see. It's rare, but it's interesting. The other point is you mentioned about pancreatic cancer as a side effect of type 1 diabetes. It's not. The poor studies were labeled type 1 diabetes as anybody taking insulin, which is insulin-requiring diabetes, not type 1 diabetes, said yes. But the good studies that look to be sure that it's really type 1 diabetes said absolutely not. So,
I appreciate the correction. Sorry, your first comment. Can you remind me?
Immune checkpoint inhibitors.
Yeah. We've been very interested in that.
Because they cause pancreas shrinkage very rapidly.
You say they do cause pancreas shrinkage rapidly?
Yeah.
Oh, really? I have not seen that. We were wanting to do a study to find that, but I wasn't aware of that.
Yeah, it's published, yeah.
Great, thank you.
Yeah. And then Dr. Rogers, that was absolutely fascinating. So everybody knows mumps can cause pancreatitis, but rabies terminally also causes pancreatitis. And rabies has been used to treat glioblastomas because of neurotrophism. Is there a way to treat pancreatic cancer with a modified rabies virus based on your findings, elegant findings?
It's going to take a braver person than me to do that experiment, but that's thinking outside the box. Yeah, that's interesting.
You're very brave.
I agree with him. I'm Tim Antorgas, radiologist from IU. My question is for Dr. Little also. Fascinating work. There is definitely something, you have an hypothesis that's why you're spending so much time and effort on this meticulous work. My question is very simple. Do you believe there is neurogenic diabetes? If you don't, then why you?
So I don't know the function of this circuit. I think it's there. There is definitely a gut to pancreas circuitry. The function I don't know. And the reason I say that is it would be very attractive to explain the incretin, to fulfill more of the incretin concept. But I can't, at this point, I can't prove to you that there are both positive and or negative influences that a neural circuit could regulate. So the neurogenic diabetes question is an interesting one, and it would be easy to say yes, and therefore I think it's going to turn out that way. There's an interesting observation looking at duodenal mucosal resurfacing, in which endoscopically they ablate the mucosa, and it cures diabetes, even though the mucosa comes back within a week or two. What disruption does that cause that is long-lasting, yet there's no anatomical or visual abnormality? And you could explain that with a inhibitory neural circuit that you're affecting. So I'm really excited. So we're planning some experiments where we're going to try to manipulate this system functionally to see what happens to islet function. So that will be telling.
So you mentioned that the rabies virus, for example, their islet cell function decreases. Did I get that correct?
So we've not looked at function with that experiment. Okay. That was just a neural tracing experiment.
Gotcha. Thanks.
So we will take two more quick questions.
Okay, thanks for me. Yeah. So thank you very much for that really interesting discussion that each of you have contributed. I was going to ask Roger about the potential for circuitry the other way, because some of the advanced chronic pancreatitis patients are really difficult, and they experience real problems eating, and their gut dysfunction is very obvious. Doesn't matter how much enzymes they have, they still malabsorb. Some of them don't even tolerate food, they can't eat, it makes them vomit or whatever. And I was just wondering if you've got any evidence or any suggestion that there are circuits working in reverse that are disordered.
I think that's a fascinating question. I've not thought about that. We've done nothing to pursue that. There are ways that you could trace, do reverse tracing and trace from the pancreas to the gut, but again, that would be an anatomical description. Functionally, I think that's really interesting. I've never quite understood why with CF patients you can give them all the enzymes they want and they never normalize their fat malabsorption. It improves substantially, but it never gets back to normal. And theoretically, you ought to be able to do that if it's simply an enzyme problem.
Okay, just one more.
I have one quick question, but I also have a comment that there are people working on neurotropic viruses to have oncolytic effects. Nina Steele, who just moved to Cincinnati, is doing that. And my question was, I know the talk was focused on islets, and so your tracing studies looked at the innervation of the islets, but when you did your rabies studies, do you also find innervation of the exocrine cells?
Yeah, we haven't looked at that in as much detail, but yes, there is tracing going into the exocrine pancreas as well.
Thank you.
Thank you, everyone. We have 5-minute break now.